Okay, we talk about the hypertensive disorders associated with pregnancy. Now, I'm going to go through the classification, the causes, and the pathophysiology, but the focus is going to be on preeclampsia. Because I have such great resources, I want to make sure I mention those. Obstetrics, the normal and problem pregnancies, 4th edition, Williams Obstetrics, 24th edition, and Robbins Pathology, 8th edition. I use these three sources primarily, and then I've used several other sources to try to work out some of the details. Okay, so hypertension, you can have a chronic hypertension. And if you remember from the video I made on hypertension a few blocks ago, you basically group it by putting the numbers 120, 140, 160. That's going to be for your systolic blood pressure. And if you're less than 120, this is normal-tensive. Between 120 and 140 is pre-hypertensive. Between 140 and 160 is going to be hypertensive stage 1. And then above 160 is hypertension stage 2. Then again with the diastolic, you're going to use the numbers 80, 90, and 100. And basically, same thing, normal, pre-hypertensive, hypertensive, hypertension stage 2. In order to classify something as hypertensive, you don't have to have both systolic and diastolic within the range. For example, somebody who has a systolic of 140 and a diastolic of, say, 85, we would still classify that as stage 1 hypertension. So with that in mind, somebody can have chronic hypertension and then get pregnant and still have hypertension. In that case, it increases their susceptibility of getting some of these other problems. Now, gestational hypertension is basically, you use those same numbers, and it's just a hypertension caused by pregnancy. It may or may not be related to some of the pathologic changes of preeclampsia. So preeclampsia, on the other hand, it's defined as gestational hypertension plus proteinuria. So you have protein in your urine and hypertension. That is the classic definition of preeclampsia. Now you can have typical versus atypical preeclampsia. In some cases you can have preeclampsia at less than 20 weeks, but typically this is going to be result in a stillbirth or in loss of the pregnancy. However, in the Baha Sabai text on normal and problem pregnancies, there is a rare documentation of a few pregnancies that become preeclamptic before the 20th week and the baby does survive. A problem with diagnosing preeclampsia is what happens when you have preeclampsia superimposed on chronic hypertension. How do you know that that preeclampsia is occurring? Now, some sources will say that an increase of blood pressure of 30 for the systolic or 15 for the diastolic can be used to diagnose preeclampsia in cases of chronic hypertension. Other sources disagree with that. And for example, Williams Gynecology, they like to use the concept of delta hypertension, and I'll let you look that up. It's a little bit complex, but it's based on the intervals of 95th percent of the blood pressure of 95% of normal women. Then lastly, there's eclampsia. This is basically preeclampsia is basically, this is what happens before you become eclamptic. Preeclampsia is whenever you get convulsions or seizures due to preeclamptic pathology. Then lastly, there's the HELP syndrome. HELP stands for hemolysis, so elevated liver enzymes and low platelets. So hemolysis H, elevated liver enzymes, low platelets. So thrombocytopenia, transaminitis, and hemolysis. So how are these diagnosed? The criteria. I accidentally put 190 here. This is 90. So gestational hypertension, just like I said, it's hypertension, a systolic greater than 140 or a diastolic greater than 90. it's happening after 20 weeks in a previously normotensive woman. If it happens before 20 weeks, typically it is a result of unmasking a almost hypertension, a chronic hypertension in somebody that is susceptible to that. So preeclampsia, it's gestational hypertension plus one of the following: either proteinuria or evidence of end organ failure. There's always going to be a little bit of protein in the urine. Usually it's not going to show up on a dipstick. Usually on a dipstick, if you have a +1 on at least 2 occasions that are more than 4 hours apart, but less than 1 week apart, you can diagnose proteinuria. However, the gold standard is to do a 24-hour urine, and if that's greater than 300 milligrams of protein, then that's considered the proteinuria. That's diagnostic for preeclampsia. Whenever you don't have proteinuria, you can have an atypical preeclampsia with evidence of end organ failure, and that's diagnosed basically from these standards right here. So how does it come about? What's the cause? There are a lot of theories have been proposed. Most of them have been disproven at this point, but the ones that are still being considered is deficient trophoblastic invasion of the spiral arteries. I'm going to go into that pretty in depth. Immune mediated, and I'll talk about that as well. Interaction with VEGF and PLGF, and so I'll talk about that as well. These other two I won't really talk about, but they are theories: oxidative stress and thromboxane A imbalances. So here we're taking a picture of the uterus. You have your myometrium, your endometrium, and during prior to implantation, you get the growth of these spiral arteries, and they just grow into the endometrium while it is proliferating. And these are pretty high resistant arteries, arterioles rather. But after implantation, the trophoblast will send in these extravillous trophoblasts will invade into the endometrium, and as well as these natural killer cells. Now, in a normal pregnancy, that invasion is quite extensive, and it causes the opening of these vessels. And typically it will invade not just into the endometrium, but also down into the beginning of the myometrium. In a preeclamptic pregnancy, that invasion doesn't happen quite as well, and the vessels are closed up extensively. So you can see the difference in how wide this vessel is compared to this vessel. So it's still a high resistance vessel. This is a low resistance, high blood flow. So a lot of blood is going to be moving into here, not as much into here. Ultimately, this can result in fetal growth restriction, so the baby can have a low birth weight, and the placenta will become necrotic. When it becomes necrotic and dies, it releases two specific soluble factors into the mother's serum. The first is soluble FMS-like tyrosine kinase, or SFLT1. This is basically a VEGF receptor. It's whenever the VEGF receptor gene, it's just alternatively spliced, and then it's called SFLT1. The other one is soluble endoglin, and this is a receptor for TGF beta. So what do VEGF and TGF-beta do, and how are these receptors that are soluble affecting it? So if I have a VEGF molecule, vascular endothelial growth factor floating around, typically here's a cell and it will bind to a receptor. However, if you have soluble receptor floating around, it's going to bind to this VEGF and trap it and prevent it from acting on its normal receptor. VEGF typically will maintain the health of the vascular endothelium, and it can also cause proliferation and growth of the vascular endothelium. So these vessels, especially the vessels in the kidney, require VEGF just for their normal health. And then TGF-beta, whenever here's a cell and it binds to its receptor, it will produce nitric oxide. It causes the production of nitric oxide, and nitric oxide, you'll remember, is a vasodilator. So it's going to cause the vessels to expand and to dilate. And when you have soluble receptors for it floating around, it blocks it from binding to its receptor, and you don't get the nitric oxide production or the subsequent vasodilation. So not only have we decreased the invasion of these trophoblasts, but we've also decreased the health of these vessels, these arterioles that are going into the trophoblast, or going into the placenta. And this will just cause a feed-forward effect where more of the placenta will become necrotic. It will release more of the SFLT1 and SENG into the circulation and cause more damage. So this leads to the question, why are the extravillous trophoblasts not able to properly migrate into and perform their function on the spiral arteries? The answer to that may be immunology. It could be immune cause. So the father's genes are not the same as the mother's genes. So every person produces their own set of proteins and genes, and every body's immune system will recognize a protein that looks foreign. So a baby has proteins that are foreign to the mother. So that's basically what I'm saying here on point 1, that the father's genes are other and would normally produce an immune response. So the baby having the father's genes, those other genes, will produce things that are antigenic to the mother's immune system. Now typically what will happen, two things will happen. The mother will produce blocking antibodies, and I've been reading immunology quite extensively, and I still don't understand where these blocking antibodies are coming from. But typically, these are implicated in things like allergies, like hay fever and that kind of thing. If you have a high IgE, it will bind to the allergen and cause an inflammatory response. But if you have the blocking antibodies, the IgE cannot bind to it, and the blocking antibodies prevent you from having an allergy. So during pregnancy, you have this placenta, and it's producing this abnormal protein, this other protein. And typically you'll have this blocking antibody that will bind to it, and it will prevent an immune reaction to it. However, if this blocking antibody is absent, this protein can be, so I'll call this a blocking antibody, a BA, and then this other antibody, this normal antibody, I'll just call it normal even though it might be abnormal in this case. This normal antibody will bind here, and it will cause an immune reaction, an inflammatory reaction. Now also, fetuses produce a type of major histocompatibility complex called HLA-G. And so the major histocompatibility complex, you'll remember, allows you to present antigens to your immune system to see whether something is normal or abnormal. This HLA-G basically blocks several steps in the immune process. Specifically, it blocks the activity of natural killer cells. So if the placenta has an abnormal or reduced expression of HLA-G, then it could incite the mother's immune system to start working against the placenta and preventing the invasion. Also during pregnancy, there's a typical ratio of Th1 to Th2, and so Th1 would be inflammatory, Th2 would be humoral, and so in preeclampsia there's a noted increase in Th1 and a slight decrease in Th2. This could create an imbalance between humoral and inflammatory responses. So you might be wondering, if this is all happening early in pregnancy, why does it not cause problems until after week 20? And the answer to that is, usually you don't get, the placenta doesn't require much blood in early pregnancy, so the blood requirement of the placenta is higher in the second half of pregnancy. And if you need more blood and you're not getting it, you're going to become necrotic and die and release those damaging factors to the rest of the body. Another question that some people are asking is whose immune system is really causing the problem? So is the mother rejecting the fetus, or is the fetus rejecting the mother? A lot of evidence indicates that it's probably the mother's immune system, and that's because you usually have a lower rate of preeclampsia on a second or third pregnancy. So on subsequent pregnancies, you have a lower rate of this problem. The reason why that is important is that it indicates a role of those blocking antibodies. It's saying in the first pregnancy you didn't have enough blocking antibodies, but you started producing them in the first pregnancy, and they increased to where they needed to be for the second pregnancy. So this is essentially like getting allergy shots. When you first start getting the shots, you're not making enough of these blocking antibodies. You keep getting those shots and you make more blocking antibodies. So essentially, by the second pregnancy, you have become immunized to preeclampsia. Now I want to point out, just like the allergy shots don't work for everybody, this is not also true for everybody. Some people get preeclamptic on subsequent pregnancies. And if you have preeclampsia in your first pregnancy, your risk of getting it in the second pregnancy is higher than the general population, but it doesn't always happen. It happens less frequently. So for example, if the general population, I'm just going to make up numbers, general population has preeclampsia 3% of the time. And then if a first term preeclamptic will get preeclampsia the second time about 30% chance. Now the fact that it doesn't happen 100% of the time indicates that there's other factors going on, that possibly you have immunized yourself. There's several other possibilities, including that the antigens displayed, the other antigens are slightly different in the other cases, but you would expect a 50% you would expect a rate of 50% in the second pregnancy if that was the case. Now, like I said, these numbers exactly are made up. I didn't go through all the epidemiology, but the evidence indicates that there is sort of an immunization process that happens in the first time of preeclampsia. Another way of describing this would be to say that if you took the general population, they have the chances of getting preeclamptic on the first term, it would be, let's say, 3%, we'll say 3% again, and then if you took the general population and their chances of getting pregnant on the second term would be more like 1%. So this would be your chances on first pregnancy, this would be your chances on second pregnancy. That's saying that you have never been pregnant before. What's your chances of getting preeclamptic your first time? What's your chances of getting preeclamptic your second time? So then this is basically a summary of what I've just said. You have abnormal trophoblastic invasion in early pregnancy. This causes a necrotic placenta in the second half of pregnancy. Then this necrotic placenta, this dying placenta, produces soluble FMS-like tyrosine kinase, which binds to VEGF. It also binds to PLGF, and then so it prevents them from acting where they need to act. And then you have soluble indiglin, which will bind to TGF-beta. And ultimately, you have severe changes in the microvasculature that cause systemic-wide changes in both the fetus and the mother. So the VEGF specifically, the glomerular capillaries inside the kidney, they're highly sensitive to VEGF. And so a decrease in VEGF will cause them to become leaky, and they'll leak out protein. Then TGF-beta, so that's where the proteinuria comes from. Then the TGF-beta induces nitric oxide production. Without that, you have decreased vasodilation, and this is where the hypertension comes from. You're also going to get an increased resistance in the renal arterioles, and this will decrease renal blood flow, and it will also decrease glomerular filtration rate. So you can actually clinically look at the urine concentration of creatinine, times it by the volume of urine, and then divide that by the plasma concentration of creatinine, and you can estimate the glomerular filtration rate. Glomerular filtration rate is usually overestimated by about 15% using this method, but it's a quick shortcut method to determining the GFR in a pregnancy. The reason for this overestimation is because the nephrons will actually secrete, they will actually pull creatinine out of the blood in the tubule. So not all of the creatinine is coming from the glomerulus. Some of it is coming from the extratubular capillaries, and it pulls it out of there and secretes it into the urine. So what are some of the other changes? Well, with the increased peripheral resistance, low nitric oxide, you have a reduced cardiac output. And then you can also, from the leaky capillaries, from the lack of VEGF, you can get edema. So fluid's going to leak out of the vessels into the tissue. Also, with all of that fluid leaking out of the capillaries, you have a reduced blood volume. So studies in 1984 and 2009 showed that the increased hemo concentration is a hallmark of eclampsia. Basically what that means, normal blood volume in late pregnancy is about 4,500 milliliters. If that volume is reduced to about 3,000 milliliters, you're going to have an increased concentration of all of those factors that didn't leak across the capillary. And that increased concentration is a hallmark of eclampsia. Now, I know what you're thinking. You're thinking, I've read through physiology textbooks and they say the normal concentration of blood, or the normal volume of blood is 5.5, so that 5.5 liters, or 5,500 milliliters. But that's average for everybody, men and women. So if you take the average blood volume for a 110-pound female, it's 3,250 milliliters. On the other hand, a 165-pound male is 5,600 milliliters. So whenever that blood volume of 3,250 doesn't go up by about 1,500 milliliters in the second half of pregnancy, that's a hallmark of eclampsia. So the next thing is thrombocytopenia, which is low platelet count. And what happens is the endothelial damage in the small vessels, the microvasculature, causes coagulation. So those platelets are just coagulating there, and that platelet deposition at the site of endothelial damage may be the cause of low platelet count elsewhere in the blood. You get hemolysis. So hemolysis is where the red blood cells break apart, and that's microangiopathic hemolysis. The red blood cells are trying to move through this platelet mesh of platelet and fibrin, and when it moves through there, it gets cut open. With liver damage, so this is called periportal hemorrhage is what happens, and it's again due to the damage of the endothelial cells. You get this, the portal vein is what goes into the liver, so the portal vein, and here's my liver. And whenever you get damage around that portal vein, you can get hemorrhage into the liver, and it can cause damage to the liver. Whenever the liver cells break open, it causes an increase in liver enzymes. And so you get an increase in liver enzymes in the serum, and this increase in liver enzymes is called typically it's called transaminitis. Some people don't like that term because transaminases mean liver enzymes, and itis is the suffix that means inflammation. You can't actually have inflammation of an enzyme, but it's a colloquial term meaning an increase in enzymes. So what's going on in the brain? There are two theories, and there's a possibility that both of these theories are correct, or that sometimes one theory is working in one person and the other theory is working in a different person depending on their physiology. So the first theory is that severe hypertension leads to cerebral vasospasms. This doesn't explain why you don't see you don't see seizures and convulsions in a person that's just normally hypertensive. The other theory, it's the acute increase in pressure exceeds the autoregulatory function of the brain. So your brain typically, if your blood pressure increases a lot, your brain will close up the vessels a little bit and keep the total pressure inside of the brain the exact same all the time. On the other hand, if your blood pressure drops, your brain will open up the arteries and allow more the blood pressure in the brain stays the same all the time. That's the autoregulatory function of the brain. And whenever you have an increase in blood pressure that exceeds approximately 160 milligrams, 160 millimeters of mercury, then 100 Hg. I'm falling all over the place saying this, but whenever it exceeds past that really quickly, then it can result in vasogenic edema. So you get edema inside your brain. So what this causes, what this results in, is you can get a headache, and that headache will not respond to normal treatments like ibuprofen. However, it does respond to magnesium sulfate. You can get scotomata, you can get visual changes, and convulsions, and cerebral edema. Now remember, whenever you have convulsions, that is defined as eclampsia. With the baby, with a decreased perfusion of blood into the uterus and into the placenta, you can have a decrease in growth. This is termed fetal growth restriction, or FGR. And I want to point out, I've only covered a few of the many symptoms that you can get from preeclampsia, but I think I've covered the most important ones. And so if you want to know more, I recommend the 3 sources I listed at the beginning of this video.